Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Let's turn to the question of someone who has been on alectinib, Alecensa, and then has been on another ALK inhibitor, say lorlatinib, and then progresses and is at the point of moving on to something other than an ALK inhibitor. What role do you see for immunotherapy? Do you think that a combination of chemo with immunotherapy, maybe with Avastin, which was the subject of a study, Empower 150, that gave carbo, Taxol, paclitaxel, Tecentriq immunotherapy, atezolizumab with Avastin, that included some patients, but not a lot, with ALK positive disease. Are you inclined to integrate immunotherapy in this setting, or are you of the mindset that patients with ALK positive disease are among the least likely to benefit from immunotherapy and that it should really be relegated to a very late line of treatment? Suki, maybe I could start with you on this.
Yeah, so in terms of the data we don't have that much data with ALK and immunotherapy from at least prospective clinical trials.
Very little, right.
Like Dr. Riess mentioned, Keynote 189, which was carboplatin, pemetrexed, pembrolizumab, did not allow patients with ALK or EGFR to enroll. There was, I think, a small subset in Empower 150 with EGFR, but again, a very small number. And then what we have is sort of retrospective cohort studies. There was this study called ImmunoTarget, where they sort of pooled a bunch of institutions around the world and tried to understand this question better, since we can't get the kind of granularity from all of our clinical trials. And as I recall, in the ALK subset, where single agent immunotherapy was used, I believe the response rate was 0%.
And I believe that's correct. Yeah.
So
I've also heard Dr. Wakely, your colleague, and some others who are up and down the West Coast, where we see a lot of patients with driver mutations, that it is exceptionally uncommon to see people with an ALK rearrangement respond well to immunotherapy. Jonathan, I don't know if your experience has been different.
I'm not aware of any. For my patients with ALK positive lung cancer, I typically do not give single agent immunotherapy. If they've progressed on all the appropriate ALK inhibitor drugs.
Does that mean that you
I would
try to integrate it earlier in combination and hope?
Yes. So I think the Empower 150, I think that's a very good regimen to consider. I mean, as Suki pointed out, the quad regimen of carboplatin, Taxol, Avastin, Tecentriq, and looking at a subset analysis, looking at those EGFR and ALK patients, granted it wasn't designed for that, did show a signal of benefit over chemotherapy alone. So if you're going to, it's all you have to hang your hat on. Yeah. It's not ideal, but it's all we have. So if I'm going to give immunotherapy and a patient's kind of fit enough to receive the quad regimen, that's what I give. I think, is that better than carboplatin pemetrexed? Or carboplatin pemetrexed, and if they've got, you're worried about, continuing the alectinib or whatever out. I mean, we don't know, but it's really all that we have to hang our hat on. And that's actually, we use it, but it's not even approved in that indication, even though that's the main population that I use it in, is those EGFR and ALK patients.
I think it's a really difficult question, because I agree it is pretty close to all we have, except for the immunotarget data that looked at the experiences from all different institutions and just brought together and saw essentially 0 for 20 something results as a single agent. the problem I see with the Empower 150 trial is that combined results from EGFR and ALK, and they don't look like they should be combined. I think that it's not clear that we should pool them together. The EGFR patients may behave differently. There were very few ALK positives, and the hints we have are that the EGFR mutation positive patients did better than all of them together, which suggests that the ALK positives pulled them in the wrong direction. So I think we're left with just not knowing.
It's so small. It's a subset it's a subset of a big trial that wasn't even included in the main endpoint. So it's not even approved for those EGFR and ALK patients, but it's what we have to hang our hat. It's the sliver that we hang our hat on.
So
I personally don't use immunotherapy in combination with platinum doublet chemotherapy because in patients with ALK, because we know immunotherapy can have real, very serious side effects. Sometimes immunotherapy side effects are fatal, particularly if you cannot quiet an inflammatory response in the lung or the liver. So without any clear data of benefit, I very much worry that then I may be exposing the patients to unnecessary toxicity. And I am very biased for use of pemetrexed in these patients because we know there seems to be some interaction with ALK, and ALK, similarly looks a little bit like ROS1, at least from a protein level. And we know that pemetrexed can work for a long time in these patients. So that's why I kind of move away from the Empower 150. I'm not too keen on the immunotherapy for these patients. And then I prefer to use pemetrexed over paclitaxel.
And my usual sequence is the TKI, the ALK inhibitors, followed by, because of the pemetrexed, Alimta, we think preferentially may work better in ALK. Carboplatin, Alimta, with or without continuing the ALK. Usually they do very well and are on Alimta maintenance, continuing it for some time. And then, when that progresses, then considering, if there's no trial, considering the Empower 150 regimen, where somebody, typically patients with ALK are, even at that point are still kind of very fit and up and about and living their lives. So I think they can tolerate it. Look for the Empower 150. That's kind of my general sequence of treating folks. But things are getting better and better. I mean, that you're talking about on average, potentially 4 or 5 years down the road. That's so at this point, maybe longer. So hopefully 4 or 5, 6 years down the road from now, we'll have some immunotherapy combination that works well in ALK. Who knows?
After first-line alectinib, do you consider among the ALK inhibitors lorlatinib to be the clear best choice? Because there are some data now with brigatinib that look like Alunbrig. Brigatinib has a response rate in the same ballpark of 40%, give or take a bit. And so I'm interested in both from the efficacy and the tolerability standpoint, how you would consider those options. Maybe I'll start with you first, Jonathan.
Well, I think, there's been some published, with brigatinib after, and I think there's a range of, 15 to upwards of that. Generally, I've used lorlatinib. I think that's one of the things to think about in terms of getting biopsies on these patients, because, at least looking at kind of preclinical cell culture data, they have that heat map of all the different mutations. And so, Alunbrig in many respects, the neurocognitive effects, the triglycerides and so forth, that may be better tolerated than lorlatinib. So I think you could come down to that heat map in terms of picking if you do have one of these on-target resistance mechanisms to ALK.
Suki, how would you rank these? And in your experience with lorlatinib, how about tolerability and managing that?
I think that in the ideal world, we could probably be more precise. And I know that the ALK master protocol, a clinical trial study that looked at all the different patterns of resistance mutations and what ALK inhibitors should you go to next is trying to answer that question. It is kind of like the pie in the sky dream study, because I think we can be more precise. But as we do see emerging data on regatinib or Alembreg versus Lorbrena, if we continue to see similar efficacy numbers post Alcenza, then I think we may have two options. And, the Lorbrena toxicity,
being the lorlatinib, yeah, just to make sure that people know. I just don't remember myself all of them. Yeah.
So I think the toxicity is probably manageable if you know how to take it on. And I like Dr. Riess's advice to read this oncologist article, because it is very, very helpful.
Author of that is?
I cannot recall who the first author is. Yeah, but I can send it to you. And then to also know that a lot of the toxicities are dose dependent. So I know I've heard Dr. Shaw say that she actually starts the dosing at 25% lower the dose. So it's usually at 100 milligrams, but she'll start at 75 milligrams, because a lot of these toxicities and side effects are dose dependent.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.